Well, hello, everyone. Welcome to SPEED, another webinar from Society of Pediatric Echo. I'm Neha Soni Patel, the co-chair of the Education Subcommittee, and along with Dr. Chen Kovu, tonight our webinar is to V or not to V. As you know, by now the SPEED sessions are 30-minute tidbits of education. It's a big collaboration between our sonographers, fellows, physicians, and this is an informal platform. We encourage you to type in your questions as our speakers give their presentations. We'd like to thank our institutional sponsors, Seattle Children's, Lucille Packard Children's Hospital at Stanford, Nemours Children's Health, Cincinnati Children's, and Ann and Robert Lurie Children's Hospital of Chicago. If your institution is interested in being a sponsor, please email us and mark your calendar for the next speed that will be occurring on March 27th. Jen will give you some more information.
Next slide. All right. Well, welcome to our SPEED, and we just want to invite you on our next SPEED webinar on March 26, Imaging the Interstage Tips and Tricks. And same time, 8 p.m. Eastern time, 5 p.m. Pacific time, and 9 a.m. Tokyo. Next slide. So basic rules, this is SPEED, but our maximum, we usually have 30 minutes, but we can extend up to 15 minutes more to up to 45 minutes. You're going to be muted upon entry, and participation is encouraged. So you can put your question on the Q&A and or you raise hand, and maybe we can unmute you when called on. Next slide. And stay tuned. There is a new member discount coming next week. We will have 50% off for new members. And so those who haven't renewed, this is the time to renew. So you can participate in the next SOPE social at ACE, at the A Scientific session in Portland. Next slide. So without further ado, let me introduce our moderators, Jenna Keelan from UT Southwestern Medical Center and Dawn Park from Johns Hopkins All Children's Hospital. Jenna and Dawn.
Hi, everyone. Thank you so much for joining us tonight. So our first speaker tonight is Dr. Deb Ho. She is a clinical assistant professor at Stanford, where she specializes in echo and fetal cardiology. She is the Associate Chief of Ambulatory Cardiology and the Medical Director of the Stanford Complex Biventricular Reconstruction Program. She completed her categorical fellowship in advanced imaging training at Children's Hospital of Philadelphia. So Dr. Ho, take it on.
Thank you so much. So I'll just go ahead and share my slides if I can. Thank you. Okay, so this is a big topic to cover in just 10 or 15 minutes. So my goal here today is just to talk about some considerations that I think are important whenever I'm evaluating a patient and a family for a 1 versus 1.5 versus 2 ventricular repair. It's really such an honor to speak in this forum. So thank you again to the SOPE organizers for having me. In some ways, the answer is like a simple answer, and the best option is the option that's right for the patient. And I don't mean for this to be trite. I think I mean not only what's right anatomically, but also what's right for the family. And I think one of the things I spend the most time on when I'm counseling families is discussing what their vision is for their child. Some families are much more comfortable with accepting kind of a more complex, potentially higher risk surgery up front for a potential more durable long-term repair, understanding that might be in a more complex perioperative course, versus other families who would prefer to have a little bit something more straightforward, understanding, for example, like in a single ventricle palliation, that long-term there are known complications. So I think that's a really important aspect, to have those open conversations with families. And also, I think about this a little bit like parenting. You know, you really want to push the anatomy just enough that it achieves its full potential. We have to be very careful not to push it so far as to backfire and make it dysfunctional. So it's a delicate balance. So how do we figure out what the best option is? Certainly, you have to talk to family, et cetera, but it's also really important to get all the data that you can. Okay, so any patient that we're considering for a complex biventricular repair of any kind, we get an echo, we get a cath on everybody, and we do an MRI or a gated CT if they have a pacemaker, for example. We use the MRI to look at flows in particular. So here at Stanford, we have a fantastic MRI program where they use 4D flow a lot. And so we're able to really understand how much volume is going across certain structures to put into a physiologic context the anatomic findings. I think also, I love echo. Obviously, I'm an echo doc, but it's meaningful to have three-dimensional data when you're talking about structures that are not in their normal place. And so all the assumptions that we use in echo for EF, et cetera, are not as good when you have congenital heart disease and the heart looks different than it normally does. We use a gated CT when we're not able to get an MRI because at least you can get an approximation of EF, and we also look at mass as well if there's a concern about whether or not that ventricle is going to be adequate from a pressure standpoint. I'm also going to talk a little bit about flow equals grow, and that I think 1.5 ventricular repair is a really good option that we should consider often in these borderline cases. So this patient population is actually very diverse. I think when we talk about the 1 versus 2V question, a lot of what comes to mind is this borderline left-sided structure subpopulation. And certainly that's a lot of where the attention is. But even within this population, it's very diverse, right? So you've got patients with, let's say, aortic valve abnormalities and arch obstruction. But that's very different from a patient who has a mitral valve issue. And annular hypoplasia is also different from a subvalvular issue. And so there's a lot of complexity there. A lot of what we see in our Stanford complex biventricular program is actually this other category that I call complex septation. So it's patients whose anatomy is so complicated that the shear rerouting is technically challenging, and because of that, they've been offered a single ventricle palliation at some centers. And so heterotaxy patients with complex venous anatomy, particularly CCTGA patients with complex other associated lesions, lots of patients with double outlet right ventricle with, for example, a remote VSD, or let's say there's valvular apparatus in the LVOT pathway. We've done straddling valves, crisscross or superior and inferior ventricles. And of course, because it's Stanford, any form of congenital heart disease can come with MACAs. So we see those as well. So I want to present to you an interesting patient that we took care of recently. And, we say biventricular conversion, but in this case, to be outside ventricular conversion. So this patient came to us after repair from an outside 1.5 ventricle, outside, who had undergone Fontan completion 6 years ago. So she, of course, is a heterotaxy patient, had bilateral SVCs, interrupted IVC with right as continuation. Pulmonary veins did come in normally to the left side. She was a mildly unbalanced canal. So you can see that here. This is the right ventricle. And she had mild to moderate AV valve regurgitation and had a double outlet right ventricle with subvalvular and valvular PS. So she had a hepatic inclusion Fontan, including the azygos, 6 years ago, and actually came to us for a pacemaker revision. But when we were reviewing her, we presented to the family that she could be a septation candidate. Now, we're very careful about this because she was a very good Fontan. Fontan pressures were 13, asymptomatic, doing very well. But since she had to undergo sternotomy, the family was very motivated to move forward with a potential septation. She, of course, has a pacemaker, right? So we did a gated CT, and you can see her ventricular volumes here are small. I think this is a really important concept when you're talking about septation, especially after Fontan. So even though she started with probably 2 normal sized ventricles, these 2 ventricles together have been pumping 1 cardiac output for 6 years. And so when you separate them, each ventricle is going to be slightly small. Actually, this RV, because it's an RV dominant, with on the bigger side. But this actually worked to her benefit because the aortic valve is all the way over here. You're going to take some of that right ventricle when you create this very long pathway. That volume kind of becomes part of the left ventricular volume. So our cross-sectional imaging team actually did a reanalysis, including that LVOT baffle pathway, and that LV end diastolic volume came out to more like 51. So still small, but borderline. And so she underwent a conversion to a 1.5. She had a AVSD repair with our wonderful director of our biventricular program, Dr. Ma. And you can see this beautiful repair with minimal residual AV valve regurgitation. Here's that LVOT pathway, which is unobstructed. And she did end up with a little bit of stenosis and some regurgitation of that RVOT pathway. But, her right atrial pressure is now 7 as opposed to 13. And so it's a different course for this patient. That being said, I think it's a really important concept, and one of the hardest things to get across to my parents as I'm counseling them, that biventricular circulation is not for everybody, and it's not inherently better. So this is an interesting CHSS study by Dr. Hickey back in 2007, and they looked retrospectively at a cohort of patients where using a decision tool they had created, they assigned a value to determine if this patient was anatomically more suited to a single versus biventricular repair. And retrospectively, looking at patients who, according to their decision tool, should have gotten a single ventricle repair, but who actually got a biventricular repair, this was the actual survival curve compared to the projected survival curve had they undergone the univentricular repair. So like I said, you can't push something beyond what it's capable of being. And I think we're all familiar with what happens when you have biventricular septation failure in the classic kind of small left-sided structure situation. So you can get high left atrial pressures, pulmonary venous hypertension, the sequelae thereof, systolic and diastolic dysfunction, very difficult to manage. And these are all considerations as well in our complex septation patients, where you may have a very big baffle, a lot of non-contractile area that doesn't contribute systolic function or diastolic function. And you have to consider baffle obstruction, which can be due to the complexity of the pathways or from growth. Single ventricle, of course, we know is also not a cure-all. We know that there are long-term consequences related to either kind of circulatory failure from high Fontan pressures and the sequelae of that, and also pump failure, ventricular dysfunction, particularly in systemic RVs. And, I think that's why, particularly in our program, the 1.5 ventricular repair is so appealing. We do a lot of repairs our surgeons do a lot of repairs where there's a long LV to aorta pathway. That means you take up a lot of right ventricular real estate. And, ultimately, as an adult, your SVC is going to only be 25% of your blood flow. But you can keep your right atrial pressure or your essentially lower body venous pressure lower by having that rerouting. We do this all the time in our CCTGA program, and our friends at Boston have been doing this for left ventricles that have been incompletely recruited, so to speak. This picture, of course, doesn't depict the Glen, but they've done it for the full mustard or with a hemi mustard. So ultimately, it's a combination of looking at the anatomic and physiologic factors, balancing the risks of what the family is comfortable with, and also understanding what success is for a family. Some families want kids at home having very normal life. That's their priority. And what comes. And some families are okay with the idea that a patient may be in the hospital for 6 months or a year undergoing LV recruitment. So for each family, that's different. Briefly, I wanted to talk about flow equals grow. Of course, you've all seen this data from the Boston program where the miraculous transformation from A to B, and with data to show growth, especially with ASB restriction. but it doesn't work in every situation. So we had a patient with aortic stenosis and arch obstruction who underwent a beautiful repair and had some degree of mitral stenosis, not too small, mean gradient of 8. And this patient has no atrial communication. Okay, so full flow, full cardiac output through that mitral valve, the optimal flow equals grow situation. But unfortunately came back to us just 3 months later from her outside cardiologist with a mean gradient corroborated by cath of 17. And that's because in this patient, the primary stenotic region is subvalvar because of the abnormality in the mitral valve, where most of the stenosis was between the valve and the papillary muscles, because she has kind of like a arcade, and those had gotten more stenotic over time, those small orifices. Again, flow equals grow is important when you're thinking about biventricular conversion and our Fontans, as I alluded to in our initial case. And some patients will require an intermediary procedure like a shunt. So a shunt to volume load the ventricle to make them large enough to undergo septation. So that's an important consideration when patients are interested in biventricular conversion. So in summary, get all the data. Anything you can get tells you more about the anatomy and the physiology. Talk about the risks and goals with family. Flow equals grow, but not always. And don't sleep on the 1.5 ventricular repairs. Thank you so much. So, we're always delighted to look at, complex patients. If you're ever interested in hearing or sharing, we'd love to hear from you at the Stanford BIV program.
Thank you so much, Dr. Ho. That was a great presentation. I'm going to introduce our next speaker. So Dr. Nick Anderson is a pediatric heart surgeon and the director of the Single Ventricle and Complex Biventricular Repair Program at Children's Health Dallas. He specializes in the evaluation and repair of hearts with challenging anatomy for biventricular repair, either as a result of complex intracardiac anatomy or borderline ventricular size. So I'll hand it over to you.
All right. Thanks for having me tonight. Real pleasure to be able to speak with this audience. Let me know if these slides are not coming through. So yeah, I'm just going to jump right in and try to show you what I'd prepared today. Really thinking about kind of how small is too small. How do we make that decision, or how do I make that decision? What are the things I'm thinking about? So as we all know, these are patients we're confronted with in all of our practices. The newborn with the borderline left or right ventricle, just some echo clips showing newborns with small ventricles and the challenges this creates for decision making. This is the exact same study that Deb had shown, HSS study from 2007, which it's important to note that this study was looking particularly at neonates with left ventricular outflow obstruction. So these are your newborns with arch obstruction and small left-sided structures. And what they found was that inappropriate pursuit of biventricular repair led to a higher proportion of mortality. And so what I took away from this study is that going for broke in the neonatal period is actually quite dangerous. And the safer thing to do is to start with single ventricle palliation initially in those really marginal cases, and then work towards biventricular circulation down the road. And so this is essentially what we learned from the Boston ventricular recruitment experience, where they had single ventricle patients where with the right hemodynamic conditions, they were able to nurture and nudge that ventricle to grow. And then once the ventricle had reached an adequate size, then do a safe biventricular conversion, as opposed to trying to do it when the ventricle is not ready. So when I'm looking at a heart with small left or small ventricular structures, of course, first thing we look at is the ventricle, the size, the function, and the myocardium. So an easy measure is the ventricle apex forming, yes or no? How is the function? Is the function normal or abnormal? And then is there anything wrong with the myocardium itself? Is there EFE? Is there non-compaction? If there's healthy, normal myocardium, that's going to be a much more favorable candidate. If there's something wrong with the myocardium, some intrinsic abnormality, those are the ones you really want to be careful with. We hear a lot about ventricular volumes. People have said that anything over 20 mils per meter squared is adequate for BIV repair. And I think I'll show you some calculations, but I think that's a very dangerous threshold that should only be used if patients are neonates or very, very young, where you think there's going to be significant growth potential. And so the cutoff I'm more comfortable with is 45 mils per meter squared. And so if you run the calculations, an end diastolic volume of 20, if you assume a 60% ejection fraction, that gives you a stroke volume of 12. And if you multiply that by a heart rate of, let's say, 120, you get a cardiac index of 1.4. And so what this means is that a ventricular volume of 20 mils per meter squared does not have a survivable cardiac index unless you are banking on rapid growth of the ventricle, which does happen in neonates, but does not happen particularly well in older children. If you run the same calculation with a volume of 45 mils per meter squared, it generates a cardiac index of 3.2, which is now a physiologic cardiac index. So that just kind of demonstrates, everybody talks about ventricular volumes, but I actually spend more time looking at cardiac index, which can be calculated from our contemporary MRIs to just actually understand how much flow is that ventricle generating, and is it enough to support the circulation. And then lastly, you need to understand the hemodynamics. What are the pressures that are required to achieve that cardiac output? If the pressures are normal, such as an EDP less than 12, then that's quite favorable. But if you're requiring a very high filling pressure to generate the cardiac output that you're looking for, then that's generally not going to be a ventricle that's going to be successful long term. And then the last question is, will it grow? And the answer is yes. The ventricle will grow if the patient is young and the myocardium is healthy. These hearts, the myocardium is plastic, and there is significant growth potential in early life. But the answer is no if the patient is older, or if there's something wrong with the myocardium, some intrinsic abnormality, again, hearts with EFE or other issues. And so, when I get to these patients, I really try to get to them as early as possible, when I can actually have the most impact on redirecting the development of the heart and the growth of the heart. And as mentioned previously, the small right ventricle is much more forgiving than the small left ventricle, because you can always offload the small RV with a PFO or a Glenn. And then valve considerations, I generally shoot for valve Z-scores greater than -2.5, but it's the same thing where you really need to assess the valve and understand, is this a normal valve that's just small, or is this an abnormal valve? Is there abnormal anatomy? Is it a straddling valve, a parachute valve, bicuspid? And then the same question, will it grow or not? And the answer is yes, a healthy normal valve will grow in response to induced loading conditions. But if there's something fundamentally wrong with the valve, as Deborah showed in her presentation, that valve is probably not going to be suitable. One thing that I thought would be good to show for an echo audience is an assessment of a straddling valve. This was a recent patient of mine who has had a borderline right ventricle with a volume of around 40 mils per meter squared and a straddling overriding tricuspid valve. And I thought I could do a biventricular repair. The patient was about a year of age. And we measured the tricuspid valve, and the annular dimension was quite favorable. It was 18 millimeters with a normal Z-score. But what you need to take into account, as mentioned previously, is looking below the valve at the subvalvar pathway. And so here, in this case, after placing the VSD patch, the subvalvar dimension is really only 12 millimeters, which is pushing it. That was giving us a Z-score close to -2. And so even though the echo report said the tricuspid valve size was 18, this is the echoes coming off bypass, and you can see that the cuspid inflow is but it's certainly on the small side. So this patient did well. I had adequate tricuspid inflow, but it was pushing due to the subvalvar inflow pathway. I'll probably just show two cases. This is a newborn with hypoplastic left heart syndrome with a borderline left ventricle. As you can see here, the estimated ventricular volume was 50 meters squared, and the ventricle was non-apex forming. So we started with a Norwood operation, but I thought this ventricle might be recruitable, so I did not do an atrial septectomy in order to intentionally volume load that small ventricle. We came back at 5 months of age and got a cardiac MRI shown on the left, and you can already see the ventricle looks significantly improved, but the ventricular volume was only 32 mils per meter squared, so I was not totally comfortable doing a 2V conversion at this point. So we started with a ventricular recruitment operation, which just entailed fenestrated atrial septal closure, upsizing of the sono shunt, and then also resection of a supramitral membrane. Brought the patient back about a year later, repeated the MRI, and now we had increased the ventricular volume to 52 mils per meter squared. The valve Z-scores were now normal, and the EDP was 11. And so at this point, we went ahead and did a Biv conversion, took down the Norwood. And you can see here coming off bypass, we have normal size ventricle with an unobstructed outflow. For time, I'll just show one more case. This is a trisomy 21 patient with an unbalanced canal. In this circumstance, it's a large left ventricle and a diminutive hypoplastic right ventricle. And the patient also had severe AV valve regurgitation and pulmonary hypertension. We started with an MRI. You can see here the dilated left ventricle with the diminutive right ventricle. The ventricular volume was estimated at 39 mils per meter squared, but we did not think the patient would do well with a primary canal repair given the pulmonary hypertension and the small size of the ventricle. So I started with a RV recruitment procedure, which essentially just entailed septation of the atrium, septation of the common AV valve. This is in order to drive preload into that right ventricle. And then also placing a PA band, but then probably most importantly, going down into the ventricle and mobilizing the papillary muscles. And so for the small hypoplastic right ventricles, I think this is the most important finding that you can see on echo or MRI, and that's fusion of the anterior papillary muscle to the ventricular septum. And that will restrict the growth of the right ventricular chamber. And if you go in surgically and liberate that papillary muscle from the septum, it allows the ventricle to grow normally and typically have rebound growth in a very short period of time. And so if you look at this post-recruitment MRI, you can see this papillary muscle is now an independent structure that's no longer tethered to the septum, and that's allowed the RV free wall to grow and this chamber to enlarge. And so this patient at 10 months of age underwent completion of the canal repair. And this is his echo at 2 years of age, now showing essentially a completely normal appearing right ventricle with insignificant regurgitation. So those are just a couple cases showing the concept of ventricular recruitment and doing things to prepare the ventricle or prepare the heart for safe biventricular circulation. These are some graphs of my data, but it's very similar to the Boston data showing that you can promote growth of borderline ventricles with the right loading conditions. And it's not just the ventricle that grows. This top left is showing ventricular volume getting significantly better, but it's also the valves. This is showing bottom left aortic valve and then mitral valve. The valve structures are also developmentally programmed to grow in response to loading conditions. So you can grow a ventricle and you can also grow valves. So I will stop there. I think that's probably about my time, and I'll give it back to the moderators.
Great. Thank you so much. That was really, really interesting. All right, I think we have one question in the chat. Dawn, did you want to take that one?
There I am. So the first question is for Deb. Is there data to compare outcomes of the 1.5 versus a single V repair? Past data is not reassuring.
Yeah, and well, I agree that past data is not reassuring. And I when I think about 1.5 ventricles, I really want to make a distinction between PAIVS and these 1.5 ventricles with maybe a more normal right ventricle or left ventricle if you're doing a reverse. So I think a lot of the kind of less reassuring data comes with that PAIVS population. And certainly the data is lacking and we're working on it. We have a lot of these patients, so we're working on putting our data out there. And anecdotally, I'll tell you, our patients do very well, and they're very much asymptomatic, and by cath, they're doing well as well. So I think a key difference and something that we're all alluding to is whether or not that myocardium is normal, right? So in a PAIVS, you have this really hypertrophied, muscle-bound RV that eventually can look normal, but it probably didn't start out normal. So there's something about it that's a little bit different. Sometimes we struggle with high filling pressures in those RVs. And I think it's different when you're, particularly in our CCTGA patients, where we do a lot of we do a lot of 1.5 to offload kind of slightly abnormal tricuspid valves to reduce regurgitation. We do it for other reasons, but you've got an essentially normal sized RV with nice compliance, low filling pressures. I think in that case, it physiologically makes sense that that's a different situation than if you've got an RV with a filling pressure of 14, right? So hopefully we'll be able to answer that question with a little more data and less hand waving in the future. But I do think that there is a difference, and some of that data is based on a slightly different patient population.
One of the next questions in the chat comes from Dr. Munoz Ferris, who is asking for mitral valve growth in borderline left-sided structures other than Doppler hemodynamics. What other echo dimensions do you take into consideration? I find that Z-scores in two dimensions are very variable. I guess this could be open to either speaker.
Let's see. Yeah, I totally agree that the echo measurements are imperfect, and they can be quite variable, especially depending on what views are being presented. I think the best way to evaluate a borderline mitral is by cath data with ASD test occlusion, to really understand what the gradient's going to be after septation. Now, you also have to be taking into account the pulmonary blood flow status. If you have a shunted circulation, you may have more pulmonary blood flow emptying into that mitral valve than you will after the conversion. And then some of these valves really require just direct inspection in the operating room, because that's where you can size it with rigid dilators, but then also better understand, is there something abnormal about the valve? Is there a mitral membrane? Are the papillary muscles abnormal? But yeah, I think going into surgery, trying to get a cath with the atrium septated is probably the best information you can have beforehand.
Again, I'm an echo doc, but I agree that echo can't do everything. And I know your question is, what other echo dimensions do you take into consideration? And the answer is, I like MRIs. And of course, cath. But I think one really important echo component is understanding that valve and the subvalvular architecture and whether or not it's abnormal. And so there have been times when 3D echo has been helpful for us. Very difficult on the little babies, where often that's like when we're worried about it. But the other piece of data that we do use is MRI and understanding those MRI flows. Of course, you can't do an ASD occlusion in that case, but you can understand you put into context the gradient, right? How much flow are you putting across that to get the gradient that you're getting? So I do, again, really think that multimodality imaging and trying to find ways to understand the physiology is critical.
Those are really great answers to that. Thank you, guys. The next question is from Garrett Hill. How do you separate growth from dilatation, or do you need to?
Yeah, so this is something that we're actually trying to study more scientifically, is understand kind of what's happening during this period of growth in these hearts that we're recruiting. I think it's twofold. I think there's hearts to it. I think there's hearts that have healthy, normal myocardium, where that myocardium just didn't develop into an adequate chamber, likely flow disturbances during development. And in those hearts, I think when the flow dynamics are restored, I think growth, I think that ventricle grows, developmentally normal myocardium. On the flip side, though, I think there's other hearts where it is more of dilation, where you're forcing that ventricle to just expand to accommodate blood, but it's not really healthy physiologic growth. And I think those are the hearts where, the EDPs are high, and they don't do well after conversion. In the most recent Boston paper, they had a significant proportion of patients with, quote, hemodynamic failure after Bive conversion, which was essentially your patients with the diastolic dysfunction and the high EDPs. So I think it's twofold. I think we're looking for the hearts that have true growth potential, and we want to stay away from the hearts that are just going to dilate and create, a stiff, dilated chamber.
Yeah, that makes a lot of sense. The next thing is really more of a comment. Said, quick comment on Dr. Anderson's first case. Looks like there is an LSVC to a dilated coronary sinus. If mitral architecture is not abnormal, some of these LVs may increase in size better with transition from fetal to postnatal physiology, I guess, with more flow through the mitral valve.
Yeah, great pickup. That patient did have a left SVC, and we've seen a few of these patients now where we're actually unroofing the coronary sinus to relieve that tissue that kind of folds over onto the mitral, pushing on the mitral valve, which it really seems like it kind of restricts the growth or the inflow. Most of the times, it doesn't seem like you need to do that, but we're evaluating some patients currently where we're considering unroofing the coronary sinus to promote the growth of the mitral valve annulus. Yeah.
Okay, and next question. Is there a way to identify via echo the fusion of the anterior papillary muscle in the right ventricle?
Yes, you can see that by echo and better at MRI, but it's there on echo. Yeah.
I just have one, I guess, final question, since there's no more in the question box. So for programs that are pursuing these more complex biventricular repairs, in fetal counseling, how do you kind of address this with patients? There's already so much uncertainty in fetal diagnosis and postnatal prognosis. So what kind of strategies and techniques have you used to introduce this? Do you discuss it at the first fetal visit? Do you leave it until, the second or third? What have other programs done?
So one of my hats is I am a fetal cardiologist, and I certainly do second opinions all the time for patients with kind of borderline diagnoses in utero. And I'm very straightforward about the fact that it's very complex, that there are potentially a number of possible pathways. And I try not to get too deep into the nitty-gritty of what we're interested in, which is like exactly where the pathway is going to be, and is it a DORV or is it not a DORV? Like, I really try not to talk about those details, because then families get very overwhelmed with the number of things. So I try to talk about it in broad stroke. And I also try to emphasize that there are a lot of changes that happen postnatally, physiologic changes that can affect the way that structures, as alluded to, they can actually change in size. And one of the things I like to say is that the the child will in some ways direct us, right? So if the child shows up with it looked like mitral stenosis, but there is a supramitral ring, that's a totally different prognosis from if they have a very complex, hard to manage subvalvular issue. And so I do try to say, like, I try not to say we'll know when the baby's born, because we don't really know. Like, sometimes it takes years for us to achieve that kind of ultimate course. And so I try to prepare them that this is going to be a lot of wait and see and wait and see, and eventually the options do narrow, right? But I try to frame it as the patient will direct us to a degree, and as time goes on, it'll be clear what it makes more sense at the time. So um, I do spend a lot of time talking with my families about how having a medically complex child involves a lot of uncertainty, and that never goes away. And so it's a super challenging, very, very long, usually multiple kind of conversation situation. But I do start that conversation early on.
Great. All right, I think that answers everybody's questions that they submitted. Thank you again so much to both of our speakers. I really enjoyed the talks tonight. I think everybody did. And I think we just want to end off by thanking again our institutional sponsors that you can see listed here. All right, thank you, everybody. Have a good night.
Thank you.
Are you good for me to end it now?
Yes.
Okay.
Thanks,
Have a
Bailey.
good night.
Have a
Thanks,
good-
Bailey.
Thanks,
Thank you,
Bailey.
Bailey.